Now I invite Dr. Irshad Edavana. He is the Associate Professor and Cornea Surgeon, Malabar Medical College, Calicut. He will be talking about piercing peril, managing the penetrating injury with an hyphema.
Thank you, Dr. Rashmi, and thank you, Rashmi, for the opportunity. So I'm going to talk about the management of penetrating injury with hyphema. There is very less literature that mention how to manage a patient with both hyphema and penetrating injury. We all know how to do manage hyphema or how to when to intervene in a hyphema. So I'm discussing some topics and some important information. Okay. So, as we know, hyphema and trauma most commonly occurs in males and usually in the working class population and home, work, or other sports or recreational activities. Most of this penetrating injury will be because of the projectiles or sharp objects, sometimes because of the fall in the elderly population. So, when we see a patient, we have to first evaluate the patient's complete assessment of the eye and as the patient as a general and do the investigations. So as we know, the most important investigation is a CT scan because in penetrating injury we cannot do a B scan immediately, and to rule out the foreign body most of the time you have to do a CT scan and then identify the posterior segment fractures or any injury and plan accordingly and explain the prognosis to the patient in the first visit only and need for further follow-ups. So first test in the serious test is important for any small perforation if you doubt any leakage, and measure IOP and dilated fundus examination if possible, always colonoscopy in the later stage. So timing of surgery, most of the time we have to do as early as possible. Risk of expulsive hemorrhage and tissue desiccation should be there. So we have to counsel the patient for a general anesthesia. All penetrating injury most preferably should be repaired under general anesthesia. And during the surgery, do a minimal touch with do not use antiseptics like providone iodine to the directly to the eye in a penetrating injury, and drape should be done by the surgeon only. You have to be very careful while giving the drop, otherwise there will be expulsion of the content of the eyeball, as we know. So whenever there's a penetrating injury with a hyphema, so primary or management priority should be a stabilization of the cornea and suturing of the wound initially, and then do the wash of the blood. You can just for example, this case was a 90-year-old female. She came after a fall. So the SE is full of hyphema and there is a wound what we can see from superior limbus about about 2 o'clock to 10 o'clock. After the conjunctival exploration, the wound was like about from the 9 o'clock to 2 o'clock. So this type of wounds we cannot suture immediately without forming the anterior chamber. So carefully what we have to do, make a side port incision, make a paracentesis. So in shallow anterior chamber, if you want to make a side port, try to pinch the limbus in the same area. So usually we make a side port by pressurizing the glove from the opposite side. Here you have to just hold the tissue close to your paracentesis and make a slow side port and control side port and put some saline or visco or air just to form the AC. If it's a completely collapsed AC, then form the anterior chamber with a viscoelastic. Then start suturing the wound. After that, once the globe is stabilized, we can do the wash of hyphema. So in corneal wound repair, our goal should be a watertight globe, then wash the hyphema, anatomical restoration, and then functional restoration. Regarding the suturing, as we know, the number of sutures actually depends upon the length of the suture. Each long suture will give a compression half of its length. So when you make shorter sutures, make more number of sutures. If you try to make a long suture, we can actually reduce the number of sutures. Always pass the needle 90-degree, go almost 90% of the depth, and then come out. As we know, 1 millimeter both side of the wound, and 90 to 95% of this depth of the wound, and equal on both sides. And most of the wound will be oblique or shaved. In this types, always you remember one thing, as you have to pass the needle through the shell side. That means posteriorly the wound should be opposed tightly. Equals. So this side should be equal. Anteriorly you don't have to make the equal bites, but posteriorly it should be equal bites. Then it will not override. Always make shorter sutures in the central area. Try to make the longer sutures in the periphery. When there is a prolapsed tissue, be very careful. In this type of large penetrating wound, there will be a lot of structures that will be coming outside. Try to excise as minimum as possible, but excise the tissue at the corneal plane. Don't try to excise anything inside the eye. Try to repose it. If there's an epithelium, just to remove the epithelium, try to repose it always. If it is devitalized or contaminated, you can just cut the iris if required. So as we mentioned, try to make the side port initially, try to insert some visco and slowly swipe the tissue inside and start to suture. Just form the AC suture. After that, wash the hyphema. So once again, use long sutures in the periphery, tight sutures. In central closure, apply shorter sutures, spaced to preserve steepening. And if you have, always better to check the intraoperative keratometry to see the astigmatism. And you can use some adjustment nodes for the tightening. Then if it's a long injury from cornea to sclera, always first stabilize the limbus, then go with the cornea, then scleral side. So hyphema we can wash by using Simcoe or using IA port. Never use vitrectomy in a very severe vitrectomy port in an immediate period, because most of the time clot will can be removed with the help of Simcoe or IA probes. Using vitrectomy probe, the issue is that especially in penetrating injury, when the globe is open and even after suturing, sometimes we accidentally cut the other tissues. So be gentle in initial wash. So we can actually wait for some time after the wash. If its IOP is very high and there's a rebleed, you can intervene later also. Don't try to completely wash in the immediate setting, especially in a penetrating injury. Postoperatively, as we know, antibiotics, steroids, etc. should be given. You have to watch for the IOP since there is a hyphema also, and check for the retina and do a base scan in the later period, and gonio in the later time. So key takeaways: evaluate for a proper management, adapt up according to the injury, and always tell the patient regarding the follow-up and need for the long-term follow-up and anticipated complications. And we have to arouse public awareness regarding the prevention of these injuries by school programs or workplace initiative or media outreach. Thank you.
Thank you, Dr. Irshad, for this information.